Mr. X is a 35-year-old man who was admitted to the emergency department. He suffers from sudden onset of headache, accompanied by very bad taste, muscle weakness, severe dizziness, and blurred vision. On examination, he was conscious but not oriented. According to his wife, this happened 45 minutes before the admission when he was helping her prepare dinner. On further questioning, Mr. X admitted that he had sprayed half a bottle of Baygon insecticide in the cellar, to which he remained exposed for 20 minutes. A preliminary diagnosis of poisoning due to inhalation of carbamate poisoning was made. Mr. X is admitted to the ICU and was given continuous oxygen support and chest physiotherapy to improve his breathing. Fortunately, the clinical signs and symptoms did not require anticholinergic treatment. After 2 days in the hospital, Mr. X was stable and was transferred to the general ward, and eventually discharged home after 4 days. Carbamate was first introduced in 1956 and had two distinct qualities. First, it had very low mammalian, oral, and dermal toxicity. Secondly, it had broad spectrum of insect control. This had led to its wide use as crop spraying in commercial agriculture, as baits in the control of household pests. Carbamate insecticides are methyl carbamic acid esters. Most popular carbamates include methomyl, carbamyl, and aldicarb. People whose work involves applying insecticides and farm workers are the most likely to be affected by carbamate poisoning. A low level of exposure may result from using carbamates at home or in the yard. However, this low level of exposure would not be expected to have major health effects. Carbamate is a group of poisonous organic compounds which lack the phosphate group, unlike organophosphate insecticides. It causes poisoning through its principal route of entry by inhalation, ingestion, or dermal route. Their molecular targets are cholinesterase enzymes, particularly cholinesterase that controls the transmission of nerve impulses at synapses. Carbamates are designed to inhibit the normal breakdown of acetylcholine. Acetylcholine is a neurotransmitter produced by a neuron to transmit signals to other neurons or muscles. It is released in the synaptic cleft where it binds to its receptor on the postsynaptic neuron, inducing a signal transmission. In humans, acetylcholine plays a vital role in the central and peripheral nervous systems, including contraction of smooth muscles, regulation of heart and respiratory rates, stimulation of gastrointestinal motility, and many other functions. However, an enzyme located in the intercellular space named acetylcholinesterase is responsible for acetylcholine's degradation. Acetylcholine is degraded into choline and acetic acid. During carbamate poisoning, carbamates will inhibit this enzyme activity. It acts by occupying the active site of cholinesterase enzymes, thereby completely inhibiting the degradation of acetylcholine. This leads to the buildup of acetylcholine and resulting in overstimulation of the neurons at the neuronal junction. Nonetheless, carbamate insecticides are reversible inhibitors of cholinesterase enzymes. Their poisoning tends to be short-lived, unlike organophosphate poisoning.
The most common signs and symptoms of acute carbamate toxicity are headache, anxiety, lacrimation, contraction of pupils with blurred vision, difficulty in breathing due to bronchoconstriction, bradycardia, hypotension, salivation, abdominal pain, diarrhea, nausea and vomiting, sweating and muscle weakness. Death is usually due to respiratory depression together with pulmonary edema. Signs and symptoms vary with individual age and weight, compound, dose, and route of exposure. Next, we move to the treatment and management for carbamate poisoning. What is the first thing that we need to do when there is carbamate poisoning? For eyes, the eyes should be rinsed gently with water, ideally running tap water for 15 to 20 minutes. Contact lens should be removed if present. For skin, contaminated clothing should be removed and skin rinsed immediately with plenty of water for 15 to 20 minutes. The patient's clothes should be discarded since they absorb carbamate agents. Eye exposure may occur even after washing. If the patient accidentally inhaled carbamate gas, the person should be moved to an uncontaminated area so that the patient can breathe fresh air. If the person is not breathing, call for an ambulance and start artificial respiration, preferably mouth-to-mouth if possible. For the treatment of acute toxicity, atropine can be one of the choice. Atropine should be given beginning with 2 mg IV, repeated at 15 to 30 minutes interval. Once atropinized, a maintenance dose at 1 to 3 mg half-hourly is usually sufficient. The dose and the frequency of atropine treatment varies from case to case, but should maintain the patient fully atropinized, such as dilated pupils, dry mouth, skin flushing, normal pulse rate, and good mental state. The total dose and duration of atropine use depends on the type and amount of carbamate compound consumed. Next is ventilatory support. Intubation is strongly considered in moderate to severe poisoning to ensure adequate ventilation and oxygenation. Patients who appear mildly poisoned may rapidly develop respiratory failure due to a combination of sinus depression, nicotinic receptor-mediated diaphragmatic weakness, bronchospasm, and copious secretion. Besides, benzodiazepine also can be used. Diazepam 0.1 until 0.2 mg per kg IV can be given and repeated as necessary if seizure occurs. The early use of diazepam may reduce morbidity and mortality. Next is fluid and electrolyte balance. Patient may require extra fluid and electrolytes to compensate for the loss due to vomiting, high fever, diarrhea, and for decreased intake. Finally is decontamination. It is recommended to administer 1 gram per kg of single-dose activated charcoal or emptying the stomach by gastric lavage if the patient presents within 1 to 2 hours of a massive life-threatening GI ingestion. If the patient is unconscious, the ingestion of activated charcoal may be less relevant since the gastrointestinal stasis, which often accompanies coma, can delay gastric emptying. It is therefore recommended to carry out gastric lavage in every unconscious patient.